I'll introduce our first speaker, as Luke's already mentioned, Professor Greg Maynard, who's overdoing a number of speaking appearances thanks to the CEC and has a very extensive list of credentials, but I'll keep the introduction simple by saying that he's the Health Sciences Professor of Medicine and also Director of the University of California, San Diego Center for Innovation and Improvement Science. And that centre is really designed to accelerate inpatient innovation, improvement and leadership both locally and regionally. And I'll ask Professor Maynard to come up and present to us on building safe transitions of care.
Good morning, and thank you for having me here. And I wear actually two hats that you'll hear about this morning. I'm a hospitalist, which isn't a common term used in Australia, but it's very common now in the U.S. There's 40,000 hospitalists. They are generally adult internal medicine physicians, attending physicians who are on the front lines of care in taking care of increasing numbers of hospitalized inpatients, not just medical patients anymore. Now there's a lot of co-management, a lot of other specialties that are using the hospitalist model. So one hat is the work I do at UC San Diego. This is in La Jolla, close to my home. It's around 2 kilometers from my home, also around $3 million from my home. Because the other hat is I work as the Chief Medical Officer for the Society of Hospital Medicine, which is a professional society that represents those hospitalists that are so rapidly growing. So part of what I'm going to tell you about is our local experience in improving readmission rates and applying a model that was developed by experts within the Society of Hospital Medicine. And part of it will be about how we roll out collaborative efforts so that we have 30 or 40 or 50 sites working on readmissions together. So part of it's about the collaborative model. So I'll be trying to hit some of both of those things. And hopefully you'll find a lot of parallels that may be useful to you. I can't quite see this link, but I just wanted, no, that's okay. There's a link in there. It just was going to show some of the impetus of why we need to change care, but I think you're all well versed in that. What it really showed here was the incredible rise in cost, where if everything else had risen at the same price as healthcare, eggs would cost, $30 a dozen and things like that. We have a lot of foolish designs in healthcare. I'm sure you've been striving to improve some of those designs. We have systems where we've got super specialties in the ED and on the wards, and then you're trying to move people out of the ED, but they won't. They don't necessarily trust the people on the wards and vice versa, even though they're both very knowledgeable professionals, and a lot of that's culture and communication. And sometimes we design in flaws like, the patient can't move out of the emergency department until someone comes in and reevaluates them right after they've just been reevaluated. And we have to collect the medical history 10 times and still don't get it right. And the patient says, wait, I just told you this, right? So we have a lot of design issues. This is our RCA about why people get readmitted. It's borrowed from Chris Kim, who's at the University of Michigan. But it's things that will be familiar to you. On admission, poor communication with prior providers in the outpatient setting, redundant testing, poor medication information, limited efforts to identify upfront what might be the barriers to discharge down the road and what are the risks for readmission. During hospitalization, you've got this very complicated workplace where the consultant doctor might not be speaking directly with the person who's primarily in charge of the patient, and the patient gets mixed messages. People have problems communicating in the hospital. I've been giving talks about how the electronic health record doesn't necessarily make this better, and it can make it worse sometimes if you're not careful. Delays in interventions and all that, failures to clarify what the goals are. At discharge, we say you're going to follow up in 2 weeks, right? And we don't involve them in when the appointment's made. Discharge instructions aren't given in a manner that the patient or their caregivers can understand it. Poor handoffs, medication reconciliation. Have you ever seen MedRec spelled W-R-E-C-K, MedRec? Because it's a difficult task that often gets messed up. And we've done observation studies about how the discharge instructions go. And the timing was incredibly short, and the amount of interaction at baseline was very poor. So all these things inevitably lead to problems, including the things that happen in post-discharge. It's not all our fault, right, that why people come back. There are complicated patients who have psychosocial issues, physical issues, as well as their medical issues. Things happen and they can get readmitted. But there's things we can do in terms of communication and making sure the right person who's going to be seeing the patient next gets the word. So the problem with addressing readmissions is that you're basically addressing everything in the hospital. So your assignment is to fix all the dysfunction in the hospital to fix readmissions, because that's what it really takes. From the start, right through the care every step of the way, through the handoffs, and beyond. It's not just the hospital. So it really does involve all these things, including how to handle these challenges that we all have. Readmissions is just one part of that puzzle, and we forget about that sometimes. You've seen this, I'm sure, 100 times, that we try to set up barriers, and we do so with having dedicated, hardworking professionals. But that's not good enough a lot of times, and these holes still are there, and so people then get through and have adverse events, and we have to try to address that. So I'm going to tell you how we tried to bundle a set of interventions to address a lot of these issues. The program that the Society of Hospital Medicine came together to build was based on work by a variety of different experts in hospital medicine who've been working on transitions of care for some time, and they got together and created this bundle. It's called BOOST. Originally, it was funded by the Hartford Foundation, which is focused on geriatrics. So the original meaning was better outcomes for older adults through safe transitions. But since these problems aren't exclusive to those over 65, it now stands for better outcomes by optimizing safe transitions. Part of the problem, or part of what we're trying to do, is identify upfront what are the high-risk conditions for readmission, and then have a mitigation and communication plan about them from the start. Standardize the interventions, improve patient education and engagement, and a lot of other things I'll show you. But BOOST isn't just this bundle of interventions in a toolkit. It's an approach to collaborative improvement. So when people say that they're enrolled in Project Boost, what they mean is they've had coaching for each hospital by a clinician leader who's already done this in their own hospital. And they coach them through, over the course of 12 to 18 months, through longitudinal phone calls and webinars, to be better leaders in their own site. And on top of that, there's group webinars so that they are keeping the whole cohort together, and they're sharing their learnings, and they have a learning community and so on. So that program has really grown a lot, from 6 to over 200. The program, this model is called mentored implementation, because they're getting mentoring, the local leads are getting mentoring as you do it. And the hope is, and what I think has happened, is that not only do they get better at the project you're directly working on, but they become much more effective leaders and much more knowledgeable about quality improvement principles that they immediately turn around and apply to the next problem and the next problem and the next problem. So next time, for the second cohort, some of those people who are mentees or being coached turn around and become the coaches for the next round. These are the components of the Boost Toolkit, and 8 Ps. It's called the 8 Ps tool, and that's just a mnemonic to help people remember what these problem areas are, these high-risk conditions. I'll show you those. There's patient-centered preparation for discharge. It includes some checklist. It includes education techniques using teach-back, because we saw how poorly that was being done. Patient-friendly forums, standardized communication to the PCP, follow-up phone calls, expedited follow-up appointments. All these things are included. So it's not rocket science, it's really all common sense. It's just putting it together in a bundle. There's another program that you may have read about called Project Red, or Re-engineered Discharge. It's fairly similar to that in actuality. There's a lot of common points to it. It's just a matter of putting it together. The difference between Project Boost and Red is that Project Boost has this mentored implementation component. This is the map of Project Boost mentored implementation sites. You'll see clusterings. And those clusterings are where insurers in that state said, we're losing money on readmissions, and we're going to pay for people to enroll in these states. And we have found that Project Boost is an effective way to reduce these readmissions. And so those are places where dominant insurers like Blue Cross Blue Shield in the US have stepped up and funded these sites to participate. Because the model, while very effective, as you can imagine, is labor intensive. It takes a physician leader for each individual site. So it would be like myself coaching 5 hospitals over the course of 18 months, on top of, again, all these other tools and longitudinal webinars. So it is a fairly expensive collaborative model, but since it's so much more effective than the shallower models, and since you're imparting these skills, we think it's a really smart model that ends up paying off. If you're in Project Boost, they get kickoff training, they get both. There's Project Boost, by the way, the general toolkit's available for anybody. You can go download it. As they're enrolled in cohorts, there begins to develop more and more materials that are restricted to those who are enrolled in the active cohort. So there's a lot of sharing. There's an active community. They can email their coach whenever they want. Again, there's group webinars, and the discussions are robust and very active and very useful for people. They also have data repositories, so everyone uploads their data for readmissions, patient satisfaction, 7-day readmissions, returns to the ED, and those are tracked and then benchmarked, so people compare against each other, and then it also helps them track their own data across time. So we'll be going and looking at some of these Boost tools and resources. I've only given you a hint of what this community is like, but they actually get newsletters and whole curriculum. They get DVDs to help spread teach back, lots of slide decks to help champion the efforts, annotated bibliographies, you name it. All right, these are the Ps. Most of these just come from literature and from local experience, and they are clearly warning signs that somebody might be at risk for readmission. We're trying to focus on ones that may have remediation. I mean, there is some risk factors for readmission you can't do anything about. So for each one of these, we try to develop what are the mitigating strategies. And that's the idea behind it. So not only do you identify the risk problem, but you try to have a mitigation plan for it and communicate how far along you are for that. That means assigning responsibility for what gets done and having a common communication tool. And that's been very difficult for people to build. We're now working with Cerner to try to build some of these tools into Cerner in a special discharge module, which they'll charge you extra for, I'm sure. And it was because people were so frustrated with the electronic health record and how it didn't really facilitate this communication when they were trying to implement Boost in their settings. And they ended up doing half of this stuff on paper, and that's still the case. So we're keep trying to get a lot of these tools integrated into the workflow better, and I think we're going to see some real improvement in this in the near future. This is a paper version form, which I'm not sure you can see real well. In this particular example, some people assigned points to the system because they didn't have enough. Almost everybody was high risk in their hospital, so they assigned points so that they could triage who were the highest of the high risk. But most people don't necessarily do that. It's just an example of how they tailor it. And you can see that it's got the risk and then risk-specific interventions there and whether or not it was done. That's the idea, is that you're trying to just organize this information so that you can keep it front and center and raise situational awareness. And we very strongly encourage interdisciplinary team rounding to facilitate the same communication. There's two kinds of interventions, and one is very general. I mean, these doing better education is not necessarily something that's risk specific. Any patient at high risk needs better education and engagement, and their family does. So we use Teach Back. Are y'all familiar with what Teach Back is? So it's how I talked to my 15-year-old son when he was 15 to make sure he got it, because he'd say, and not get it. So I'd have to say, okay, what are you supposed to do then after school? And then he'd say it back to me, wrong, incorrectly. We'd go over it again and again until I was sure he got the information. Now, that's not to be condescending to the patient, but they are hit with an overwhelming amount of material when they're discombobulated by sleep deprivation, illness, stress, etc. Someone described it recently as, you know how you feel when you go from the US to Australia or vice versa when you get off the plane? Multiply that times 10, and that's how you are when you get out of the hospital. So how do you expect people to absorb all this complicated information? Follow-up phone calls shouldn't be just about satisfaction. They should be scripted. They should be hitting specific target points. They should have the medical record in front of them. And who makes that call is going to be up to the individual institution. We've struggled with how to organize this. For a while, some of our patients were getting 3 calls, others were getting none. So we had to really work on this coordination of calls and make sure that the documentation for the post-hospital follow-up call went in the same place with the same structure, and that we tagged that call so we knew if it was done or not, right? So that we could electronically tell at a glance who's gotten the call and who hasn't. These making the appointments in conjunction with the patient is very important. Otherwise, the follow-up rate plummets. So making sure they're engaged in the process, and ideally the appointment's made before they leave the hospital. It's not always feasible, but ideally that's the case. And you try to make that follow-up early, ideally within 7 days. Sometimes it can be 14 days, and you can still call it an early follow-up, but that depends on the individual patient. Risk-specific things are like if you identify a problem diagnosis like CHF, you've got your quality list for CHF. You're actually just triggering probably what you already have in terms of a CHF protocol. You already probably have a quality checklist. This just raises it up and makes sure that you trigger the use of what you probably already have in place and make sure those things are done. So it's pulling this general structure, this general organization, actually lifts the performance of all kinds of other things because it hooks into CHF care, COPD care, acute MI care, diabetes care. It's triggering the other protocols you probably already have in place, and therefore it's a way to organize a lot of your quality and safety efforts and make sure they get done. the teach-back method again. I still can't think of teach-back without thinking of my son. I don't know why it is. But there's a general checklist, and they generally, the checklist is really targeted at different points in admission, on admission, nearing discharge, and at discharge. And again, these are things that you probably have somewhere in your institutions already, and you're already probably doing some of them. It's just organizing them so that they all get addressed, and that you're trying to efficiently do this. When people roll out Boost, we try to tell them, look at what you're already doing, and don't reduplicate what you're already doing. Just make sure it's organized. You don't want to add work that they're already doing or duplicate work. You're trying to reorganize it, redesign it. The patient-friendly discharge document is very important, and we make sure it includes these things. I'll show you a couple examples. The first one's called the PASS, and it's very simple, written in lay language generally. It gives them specific instructions. And again, we're trying to make sure these get built in the electronic record as well, and that they're gone over. They become the source of teach-back. We often have the patient fill out parts of this, as we're educating them. And so it gets reinforced in that way. We're making them work too, so that's good. The Boost tools always need to be tailored to your local setting, your documentation environment, what resources you have, et cetera. And we found that's true. Some people don't use 8 Ps, they use 6 Ps, for example, because they find it too hard to do all of them, and too many people are at high risk. The model's been very successful, I think, but we're still early in the data collection. I'll emphasize that. This was just published recently in the Journal of Hospital Medicine, and they had a relative reduction of 14% with no change in the control units. It wasn't a randomized controlled trial. These are control units within each hospital where they did Boost versus they didn't do Boost. In the Illinois cohort, the readmission rate in control units didn't change, whereas they had a 25% decrease. And you saw the number of hospitals involved. This is fairly large. This was 6 hospitals, but this has since been replicated in pretty much all those hospitals that were depicted.
What was that like in real numbers? I mean, 14% to 12%.
Okay.
Only 3 admissions.
So this is a very large number of. This is a large number of admissions where the readmission rate is hovering around the Medicare average, which is around 20%. So out of 100 adult Medicare admissions, 20 get readmitted within 30 days. And these hospitals were hovering around, or they were worse than that average at the beginning, right? So it's a very high number. I didn't go through the literature, but a large number of those patients, over half, had not seen their primary care physician before they got readmitted. And they're very complex patients by and large. So getting a reduction from 20% down to 10% or 20% down to 15% is tough to do across a whole cohort. Now, some of these hospitals had 50% reductions, and some had 10% reductions, and some had no reduction. But overall, if you're trying to organize this across 30 or 40 hospitals or whatever, it's a big achievement to get a 25% reduction in readmissions. I'm going to tell you our local experience. So I'm at UC San Diego. We have 2 campuses, 600 beds, 600 acute beds. We're the only academic center in the county. We're buffered from the LA monster by a large military base that keeps them out of our hair. And we've really worked a lot since the 12 years since I've been there. They've really progressed beautifully in terms of their culture, their quality improvement and safety efforts. And we use Project Boost as sort of the framework for our own readmission efforts. And I acted as my own coach. But we didn't just use Boost. And one of the messages I want to tell you is that you can't just work on your inpatient design and hope to get big readmissions. You've got to involve the community, and you've got to have things that connect with the outpatient setting, and they have to be involved. The skilled nursing facilities have to be involved to make this happen. We have a couple other programs. One's called the Care Transitions Intervention, or CTI. It was pioneered by Eric Coleman at the University of Colorado. And that's, as opposed to working on the inpatient process, it's generally an outpatient-based coach who comes into the hospital and you identify patients who would benefit from better patient engagement and would benefit and are able to become a better self-advocate in their own care. So they basically identify these patients. We identify them through Project Boost, through the APs, and through interdisciplinary rounds. The care transitions coach comes in, they work with them, they give them an electronic, they give them a personal health record, they do an interview, and I'll show you some of the other things that they do. The other federal program we have is called the Community-Based Care Transitions Program. And that is a large government program where they're funding regions or groups of hospitals to work with their community-based organizations. In this case, it's our county services. And the county, the outpatient entity gets the money. The hospitals get almost no money. And so it's skewed towards spurring the use of the care transitions intervention, but it's really spurred a lot of interaction between the communities and the hospitals to the point where these silos before are really working well now and much better. I think part of this is from Obamacare, which is the Affordable Care Act in the US. It's a controversial act, but I think most physicians are for it. They know that the old system was really stupid, and we were incentivizing overutilization. We were incentivizing siloed care. The new programs rolling out are really starting to work and take hold, in my view, in terms of fostering the inpatient and outpatient communication and community teamwork. So for these Boost teams, you generally have to have an advisory board with members of executive leadership. You have a core Boost team who's going to be usually a physician leader, a nurse leader, a pharmacist, often a case manager or social worker. And then you've got a lot of ad hoc members who come in and out. But they have to be involved in frontline care and understand that work. They can't be just executives. We often have to, because this is an overwhelming job, as I was saying, you're trying to fix everything, you end up uncovering all these flaws in your system in terms of communication. We tried to map out the process when we started this, and there was no process. It was so variable, it looked like spaghetti. It wasn't a process map, it was LA freeway. So what you find out is you have to have working groups working on specific barriers, and then the executive advisory board is empowering that subgroup to make the changes necessary, because these themes that are acting as barriers to care keep coming up over and over and over again. And unless you fix it, nothing happens. I'll give you one simple example. We couldn't even, I was amazed to find how inaccurate the listing of the primary care provider was in our electronic health record. And when we went to the electronic health record, that primary care provider listing no longer was just a matter of, oh, that's not the right one. I'll make sure you go to the right one, or the patient will figure it out. Suddenly, that listing would direct the routing of all the materials in the electronic health record through the communication managers. So if the listing wasn't right, the right person didn't get the follow-up discharge summary, for example. So it was incredibly hard to update the provider directory and to make sure everything was accurate, and to put fail-safe mechanisms in place to make sure that before the patient left, the provider was listed correctly and that it was routed correctly. Just one small example of how you think something simple is actually more complex and you need a special team just to get it done. This is the care transitions intervention I was talking about. So they had very impressive results in randomized controlled trials. And this drove a lot of change in the US in terms of policy and how they set up regulations around asking patients certain questions that address preparedness for discharge. Our HCAHPS, as they're called, scores or patient satisfaction scores include things that came directly from this. The CTI coaches do these things, and they're key to help this subset of patients who are amenable to activation and better engagement in their own health care. They've been very, very effective in our setting and across the US if you select the patients correctly. They get referred and they come into the hospital. They're one of the people who might be making the follow-up phone call to the patient. That's, again, another reason why we have to coordinate these calls. They get a home visit, phone calls, and then we have something in our county called Enhanced CTI, where they really do a good job of hooking them into all the social services, rechecking the paperwork, helping them navigate the system. This large program we're involved in, San Diego County has the largest CCTP area. It's a very high budget thing, not for each individual site, but because there's a lot of people involved. And they're spread out all over the country. We have 11 hospitals in our county participating. They're competitors, and yet they're collaborating, sharing information, and all the emergency departments are involved. The inpatient settings, we're having regular meetings with the skilled nursing facilities. We have data on which ones have the highest readmission rates to our hospital. We're putting providers out in those skilled nursing facilities to facilitate communication. We're doing root cause analyses and things like that around why it's happening. And we've developed in our own setting, we've realized that these roles are so effective, we've created this sort of specialty, almost a new specialty in nursing, this transition nurse specialist. They have this blended role, and their whole role really is to be part of this interdisciplinary team, these interdisciplinary rounds. They follow up on the triaged high-risk patients and triage them further. They are monitoring the process to make sure that we're following through on things. They're doing some of the teach back, but more importantly, they're teaching others how to do the teach back education better and do the educational programs. They are so psyched up about their work right now. They are so enthusiastic because they see that what they're doing is making a real difference, and that they've seen all these cracks in the system, and they're the ones now out there helping to fill it, and they get the immediate feedback from the families. They see what happens when they fill these gaps and they identify something that would have previously resulted in patient harm or readmissions. And they are, I just can't tell you how excited they are about their work they're doing now. So they are, it's tough work, and they feel like they're running around a lot, but they're really excited about it. This is their workflow. There's a lot of communication involved, a lot of follow-up. Patient follow-up after discharge, there's a lot of these red flags. We try to make sure people have a reliable number to call in the interim between when they leave the hospital and when they see their outpatient provider. We haven't always done a great job with this. People would put in the general hospital number, leaving the patient to call the operator, and then having the operator guess who to call. So we've really been clamping down on this, making sure that each service has a reliable number for that gets to a doctor to call back. Or if they have a mid-level provider or whatever, they set up a system so that the patient gets care, and instead of the patient having to call 4 or 5 different places, we're installing triage trees so that they know who to call for each different kind of problem. the onus shouldn't be on the patient to call from place to place to place to find the right person. The first point of contact has that responsibility. So again, this CTI does a lot of different things, and they communicate regular with our inpatient transition nurse specialist, and it's really become a great inpatient-outpatient partnership. The pharmacy interventions are key as well. I think the two most important things here are the transition nurse specialist and that CTI nurse and the medication management piece of this, as well as fostering the interdisciplinary rounds. They help target higher risk patients to make sure the MedRec gets done correctly, and work on things throughout the spectrum: admission, discharge, and post-discharge. And there's so many patients in an academic complicated center are on so many complicated beds that they really do need this help and benefit from it. They're catching errors all the time. There's a program in SHM, Society of Hospital Medicine, called Project Marquee. It's starting to publish a lot of studies around MedRec and best practices for doing it. Increasingly, they're putting what they call pharmacy assistants, or they call them different things, but they're putting them in the ED to make sure that the MedRec gets done before they hit the floors for those targeted patients, because it's just too hectic in the ED to get it done right, and relying on the intern or your first year house officer to do it correctly every time just isn't working. Especially when we got to the electronic medical record. We had made great progress on our medication reconciliation. We implemented the MedRec and the EHR, and everything went to hell. It didn't help. It made it much, much worse, because the complexity, and it's not intuitive about how it's working, and you don't realize that suddenly you're generating executable orders. So we had to do a lot of work around this, and it's still not perfect, but it's certainly much better. They get a record that looks like this for their meds. Okay, it's a medication management program. It has a picture of the pill. It puts things in their language. It's not just coming out of Cerner or the EHR, it's a special program. Unfortunately, it takes currently extra work because they have to input it. It doesn't port from the EHR into this program. They have to enter it. But for these high-risk patients, it's often worth it, and helps keep them out of the hospital and helps make sure they're on the right thing. It also ends up being a nice teaching tool that they use in TeachPack. In our site, we see that these interventions come up at every phase. And so these interventions, they can't usually just be a one-touch thing, because one touch generally isn't enough. We've had good results with this program. We're reducing our readmissions pretty significantly. We've reduced them further since this slide. Cardiology is an example, from 17% to around 12%. Hospital medicine is the largest service by far in our hospital, and the 7-day readmissions come down as well, of course. So most of the readmissions occur in the first 15 days. And we also monitor things like return to ED. This is discharge summaries. When we started, we had a standard that was started for completion of discharge summary. That standard was set back in the 1950s. And the standard was the discharge summary should be completed within 2 weeks. That's not a very acceptable standard in our view. So this is completion within 2 days, and the great majority of these are done before the patient leaves the hospital. So we've been tracking this for a while. This is hospital medicine. Other services are now picking up the pace. They're nearly at this mark as well. All right, so like I said, it's a sobering task to take a charge at readmissions in general, just like it is for the patient flow things you're doing, because you find out it's not just an ED problem, it's something that goes across and is more pervasive than that. You have to work on a lot of different things. The transition of care isn't just a medical event, it's also a cultural thing, it's a whole transition of environment. There's a whole host of education, psychological issues going in there, community support issues, and patients most often don't get readmitted for the same reason they were in the hospital for the first time. They very commonly come in for something else. There's a lot of recent papers on post-hospitalization syndrome. I don't know if you've heard about that term or not, but it just gets into the fact that being in the hospital is the highest risk for hospitalization that there is. And a lot of that has nothing to do with the primary reason they were in the hospital for the first time. It has to do with this debilitating effect of being in the hospital and being sick in general. And you know, the increased incidence of delirium and all those things that come with hospitalization. Some of that, we're starting to work more and more on things like, you know, keeping the wards quiet, better sleep habits, not waking up the patient for vitals at 4 in the morning if they're resting comfortably, things like that. We used to view transitions of care or the discharge process, or however you want to call it, as a hospital problem. But this is clearly not a hospital problem from the patient's point of view. The patient has one experience that goes across all those spectrum of care. And you know, the responsibility for the patient doesn't end when they leave, and increasingly our inpatient settings are realizing that. The entire continuum of care has to be there. And of course, executive support has to be there. Since the ministry's here, I'll say the ministry support's necessary as well in your setting to get this done and to build these partnerships and to provide the support, sometimes incremental resource to do this, because this is very hard work, but well worth it, and patients are gratified with the results and really much happier for it. So we have some of these, we have, as you know, a fractured, weird health system where our payment comes from different kinds of payers all over the map, but we're trying to be relatively blind to that and view these different payment streams as just a way to do the stuff for some patients and get paid for some of the patients that, to provide the standard of care that we're really trying to provide for all patients. And I'll just end with that central thought that you're trying to identify problems, mitigate them, and have a communication plan that goes across disciplines so that you can tell what's done and what's not done. It's simple organization, but since it's not simple, in reality, it's hard to pull off, and it takes practice. And I'd advocate that you, as you try to work on this sort of thing, that you really build an effective collaborative structure to help share information and promote coaching and local expertise as you go. So the future state is on admission. You do a risk factor screen, a discharge needs analysis, you do this general assessment of preparedness, do good med rec. If the patient gets readmitted, then there's an immediate root cause analysis, not a full-blown one, but there's a structured analysis about why they came in. That's been very helpful for us. During hospitalization, interprofessional rounds become the rule, not the exception. You initiate readmission risk reduction interventions and educate the patient better with teach back, clarify the goals of care. You make sure that the patient's involved in the post-discharge appointment with patient-friendly instructions, involve the family when available and necessary to do so. Have good follow-up phone calls, and everybody's happy, of course. Now, as I said, this won't fix all the readmissions. Patients get sick, they come back in. But these efforts have led to all sorts of energy in other areas. So, you know, somebody comes in and they were just in the hospital. They were obviously at the end of life. Nobody had the conversation. They get readmitted 3 days later. Root cause analysis is done. This comes to the attention of the executive council, and you know, you start putting things in place to monitor for people who are obviously near the end of life and make sure that those conversations are had, as an example. So we're going to try to block those holes now with systems approaches so that the patient doesn't have adverse events. I think in the past we've had this fractured care, but very much so I feel like it's coming together now that these segments are coming together and people are coordinating this better in our county, not across our whole country, but certainly in our county it's really starting to come together. So I'll stop there, and if we don't have time for questions now, we may have. If not, I'm going to be sticking around today, and I'll be very interested in hearing what you're doing with patient flow, and with your work in that, and with your thoughts on readmissions. All these things are interlinked, and I'm looking forward to learning from you as well. So thank you for your attention.